All right, everyone. Up next, we have Brent Ness with Aclarion Incorporated. Give him a hand.
Thank you very much. I appreciate the opportunity to visit with you all today. Here are my standard disclosures or disclaimers. The problem we are solving is the single largest expenditure in all of healthcare. It is the chronic low back pain problem. And if you look at the right side of this slide, or I'm sorry, the left side of this slide, you'll see what physicians have to deal with when a patient comes into their office. They come in pain, and they're trying to identify the source of that pain. Now, the issue here is that the variability that comes from that, from physician to physician across the country, is tremendous. This variability is expensive. It leads to poor outcomes, which really is the definition of low value care. What Aclarion has been able to do is identify the discs that are actually causing the pain. This lowers costs, it leads to better outcomes, and by definition is high value care. Now we have evidence to support this, and it comes from the GORNET trial, a GORNET study, where 139 patients came in with chronic low back pain, 73 of which underwent surgery. When the surgeon operated on levels that corresponded with the NOCI scan report, the outcome in year one, the positive outcome, was 97%, compared to 54% when there was a discordance in the level between what was treated and what the NOCI scan indicated was painful. 97 to 54. Now, this slide is showing you the durable nature of that at 85 and 63. So we have durable outcomes at 2 years when NOCI scan was followed versus not. Now, what does that mean economically? We had an independent healthcare economist PhD run those numbers with some industry assumptions, and it showed a dominant conclusion, both economically and clinically, in such a way that it can save the U.S. healthcare system nearly $500 million. Now, these were very conservative assumptions, frankly, that were put in there, but you know what? That's what healthcare economists PhDs do. So we'll take what we can get. Now, you're going to see in the next few slides that we are very committed to evidence, because the way that healthcare technology companies succeed is bringing evidence to the payers with their KOLs. I'm so excited to say that we are launching a national randomized trial called the Clarity trial. The GORNET evidence is fantastic, but that was a single site, single surgeon. What we're doing here is we're actually going to be having 2 cohorts, multiple institutions across the country, and one of the cohorts is going to be blinded to NOCI scan, and the other cohort is going to use NOCI scan. And then we're going to let the results speak for themselves. We really think this is going to be a mic drop kind of evidence trial. We just announced last week that we're being utilized by the LifeHab trial in Norway. This is 140 patients are going to go through the NOCI scan, and it's going to help them determine conservative therapy versus surgery. You'll see here, we've been hired by the NIH to participate in 2 different studies, the Backpack study and the BEST study. So the list of hospitals and facilities that have utilized this throughout these trials is listed here. You can see on the bottom and right-hand side, really leading institutions throughout the healthcare system in the United States. But it doesn't stop there. We're also utilized in Rome for this particular study. And what is this now? Let's get into the science a little bit. What we do is use MR spectroscopy. So just like a normal MRI machine, but instead of creating that picture that I showed you on the first slide, what it does is it measures the content inside the disc, because as it turns out, your disc is full of either healthy or not so healthy biomarkers. And to make this easy to understand, you have structural integrity markers that are like the frame of your disc. As those degrade, nerves come into the disc. If the disc is full of pain biomarkers like acids, acid hits the nerve and causes pain. The problem is you can't see pain. And if you write down any note from this talk, you can't see pain, but you can measure the biomarkers that create a painful incidence. And that's what we've done. The separation using the ratios that we use here are very clear. Like we can absolutely identify a painful versus a non-painful disc, and this has all been studied very rigorously. Now, what are we competing against? This is probably the most fun slide of them all. We are a non-invasive, objective, because we're measuring actual content, biomarker content, not painful. It's an MRI experience for the patient. There's no radiation. It can be added to a standard lumbar MRI study, takes about 25 minutes, and it's half the cost of the gold standard. Now, you're gonna be shocked at the gold standard. The physician actually takes a syringe and inserts it into multiple discs and pressurizes those discs until you basically jump off the table with pain. And oh, that's the one that it's L4, L5 that's painful. So it's a medieval kind of gold standard that we're competing against here. And the physician community, it's really falling out of favor, but the physician community is excited to have an alternative that is objective as well as not painful, because the patients certainly are not a fan of that one. But they go through it because they're in chronic pain and they want the solution and they want the physician to treat the right level. Now, our intellectual property is fantastic. We've got 22 issued U.S. patents, 17 international patents, 13 pending, and we've got an exclusive license to use this technology globally and into perpetuity from University of California, San Francisco, where the technology was invented. Now, the IP broadly covers the use of proprietary biomarkers and the ratios of those biomarkers inside the disc to identify clinically painful and non-painful discs. The post-processing that we've been able to patent is also an enhancement on this spectral data, this MR spectroscopy data. And then we've got a patent on the use of AI to correlate that to outcomes in the future. So when we talk about future product development 3.0, the use of AI correlating to those outcomes that we're going to determine through the Clarity trial and et cetera and ongoing use will help us very quickly ascertain whether a patient needs treatment or not using this technology. Now, the product status. We currently have it in play, as I mentioned. We've done over 1,000 commercial scans, so we're in the market. We have revenue. The next generation is that AI tied to outcome product. We have regulatory approvals in the United States, so we're FDA cleared. We have a CE mark. This is all great. And then the predicates for the AI product will be HeartFlow and Clearly, two companies with which I have been employed. So we've got a pretty decent understanding of how those predicates are going to work. Now, the market opportunity. Like I said, this is the largest single spend in all of healthcare. There are roughly 550,000 lumbar fusions per year. It's a $10 billion market. Our list price is $1,450. We think once the insurance carriers come on board with this, we're going to see a pre-authorization kind of rule put in place for many of them. So you pre-auth 550,000 fusion surgeries at $1,450. You can do the math. It gets to be a pretty big number in a hurry. Now, that's just the fusion marketplace. When you start talking about other spine surgeries, it gets to 40 billion. When you start talking about the treatment of low back pain, chiropractors, physical therapy, all of that, it gets to 135 billion. So again, 266 million people in the world suffer from chronic low back pain. We have Category 3 CPT codes. Now, this is the mechanism with which healthcare dollars flow. A physician or a hospital treats a patient, they bill these codes out. So we have our own dedicated set of codes already in play. They're Category 3 codes. We need to transition those Category 3 to Category 1. But the fact that the AMA has issued the codes and we have them in our hand today enables us to move to this very well understood strategy. We are moving to standard of care. Nothing in healthcare, right, gets to standard of care without reimbursement. You get to reimbursement by having key opinion leaders, and I'm talking about the luminaries in the field, take your evidence, like the Clarity trial, like the Gornet trial, like all these other trials that we're involved with, and their own experience to the medical directors of the payers. So you can see in this light green area in the middle that we're talking about healthcare economics. We're talking about scalability and coverage and reimbursement. So the codes help us get there. But believe it or not, they don't care when I call. Blue Cross Blue Shield doesn't care when I call them up. They want to hear from the KOL. So again, their utilization of the technology, their presentation of the evidence is the key to get to that biggest catalyst that this business will experience, which is our first local coverage decision from a payer. We don't have it yet, but we are, we're coming. We're coming not with me again, but with this list of luminaries. And if you look across this and go to like the North American Spine Society meeting or the Congress of Neurosurgery or any number of other societies, these are the people that are on the podium. These are the ones teaching the other physicians. These are the ones that have embraced the responsibility to evaluate new technology and to bring it to market, so that when Sig Bourbon from UCSF picks up the phone and calls the medical director of orthopedics at Blue Cross of California, they answer the phone. They listen to them. They get the audience. So I'm so proud of this group that we've assembled here for a company our size. And it's really about how game-changing the technology really can be. So game-changing that probably the darling of the spine industry in terms of spinal implants and capital equipment in their EOS technology has entered into an agreement with us. This is a company called AlphaTech, commonly known as ATEC. ATEC has hundreds of salespeople throughout the country. They've got KOL relationships of their own that are fantastic, and it's a 4-phase agreement. If you go back into our press release history, you'll see exactly what those phases are, but essentially their KOLs are going to study it. They're going to figure out how it will fit into their Alpha Informatics platform. They're going to co-market with us in specific markets with their sales force, and then we're going to grant them exclusive use of NOCISCAN within that AlphaTech Alpha Informatics platform. Now, that doesn't mean that others can't order it directly with the CPT codes. They can and will, but in terms of bundling the offering within another broader solution, outcomes-based solution, AlphaTech will earn that exclusivity. I want you to feel comfortable that we actually have been here and done this. We know what we're doing. Jeff Trayman, our executive chairman, is an exceptional leader, West Point grad, board-certified neurosurgeon from the BNI, but he's no longer practicing. He's a serial entrepreneur. He's got over 100 U.S. patents himself. So when I need to bounce something off somebody about, what is the market going to think about this? He was the market. He had to live through the challenges of actually finding the source of pain and treating it appropriately. John Lorbecki and I worked together at Medtronic. John is our CFO and excellent, smart CFO. Ryan Bond has been leading our strategy for several years now. He predates my coming on board. He worked with NuVasive and really very dialed into the spine community. I have experience from imaging. I worked with GE Healthcare, with Philips Healthcare. I was the Vice President of Global Sales and Marketing for a division of Medtronic. That's where I got a lot of spine experience. And then I also worked at Clearly. I was the president of Clearly in the cardiology space and the chief commercial officer of HeartFlow. HeartFlow's, Silicon Valley unicorn. And it is the exact same business model. Imaging to the cloud, create value, bring it back to the treating physician so that they can make a better decision. So the same business model, same code sets, same reimbursement, same KOL strategy. We've been here, we've done this, and we know what we're doing, and we're not, floundering around wasting a lot of money. Our board is also absolutely fantastic. Bill Westman, lead independent director. Steve Deitch is the CFO of Paragon 28. Amanda Williams, quality regulatory vice president of ViewRay. And then Scott Breitbart, Dr. Breitbart has worked in the payer community for years and years. So I think we've augmented the management team with a really strong board who helps us out. The financials, we've got over $1 million in cash. Since this, just as of December 31st, we've retired more than half of that debt. We're down to about $800,000 in debt, roughly. And we're burning about $400,000 to $450,000. And a lot of that money is going into the Clarity trial. So our CRO, so we're investing dollars. There's not a lot of headcount burn. We've only got nine people on the payroll. So you can see we're managing cash very conservatively. Now, the key takeaways here: we're addressing the leading cost in the healthcare system. Over $135 billion market when we get there. That's the U.S. only. We are the only non-invasive diagnostic that is identifying pain in disc, the only one. We've got 39 issued U.S. and international patents with another 13 pending. That patent portfolio is the envy of GE and Siemens and Philips in terms of the use of spectroscopy to identify and separate out those biomarkers. It really is very, very strong. We've got an incredibly strong value proposition for patients, doctors, payers. All of the stakeholders here are benefiting. Our CPT codes and regulatory path is in place. We're ready to go. And we've been here and done that, like I said. So with that, I'll take any questions. Yes, sir. No, it will not. We'll be able to launch it and move it forward, but we've got a very good relationship with our CRO who understands that we're going to be, moving to gain more financing during the trial. And we do have revenue coming in as well, so we're working hard to make the revenue, a big piece of what we're doing. And we're getting paid for those trials, by the way, like that LifeHab trial. They pay us for every scan that we do. We've got a relationship, a commercial relationship that's previously been announced with the London Clinic. And that market, I'm super excited about the London market. Very thoughtful people and a thoughtful payer community over there that, again, we're in those discussions now with the key opinion leaders and the payers. So, nothing to announce yet, but I'm hopeful. Yeah. Yeah. Yes, sir. Yeah. Good question. So it's a gross margin question. We really have very low costs because when that image, that raw material, that spectral data comes to us in the cloud, nobody has to touch it. We do touch it. We do look at it, but we don't have to. 80% of these things are just generated automatically and can flow through. But we've got a quality assurance system that we go in and look at them, but we don't need to. So it approaches 96% gross margin. I mean, huge. So at scale, you can imagine here, if we can get that pre-authorization in place and we start to drive volume through this business, it's insanely profitable. Yes, sir. $1,450 is our list price. And let me just say that if you look at other companies in this space that are doing similar things to what we're doing, taking imaging as a raw material up to the cloud and back down, when they've moved from category 3 to category 1 codes, it was a very similar list price, and they ended up at about $950 for reimbursement. So $950 on a COGS of $20 is a pretty good business model. Yeah. Other questions? Yes, sir. No, we cleaned up the cap table when we took it public. It was, in business for several years, had, lots and lots of people on the cap table, individual investor types, but no, one single type of share. Yeah. Yes, sir. Yeah, I hope not. The question was, are we going to be consumed by a larger player, by a Medtronic or by someone else? I really hope not. I think we're the platform company that can pull in these other AI-based radiology solutions. That's why we changed the name from NOCIMed, which was, NOCI is Latin for pain, to Aclarion, because we don't necessarily just want to be in the pain business. Yes, sir. Spectroscopy, MR spectroscopy. Mm-hmm. The question is, what else is MR spectroscopy used for clinically? And it's brain, breast, prostate. And again, our IP can be applied to all of those areas. We're focusing on the biggest spend in healthcare. And oh, by the way, the size of the voxel prescription, right? The size of the target area that we've been able to achieve in a disc is a huge achievement. Usually you need more tissue to measure, but the fact that we've been able to do it in a disc is really, really fantastic. So migrating back out to larger tissue areas won't be technically difficult at all. Yeah. Yes, sir. Most can go into an MRI, most implants, but there is an issue with noise, signal to noise, and some interference artifacts. So pre-existing, the question was, can implants, people that already have implants in their back, use this technology? It's not in our indications for use, but we have been successful if it's farther away from the implant. Yeah, good question though. Yeah. Yes. So the question is, are there any obstacles scaling this globally? Absolutely none. Other than getting regulatory approval, which we already have in Europe, there's really just that, the pipes, the Umbra pipes, if you will, of moving that data can do so over the internet. And so we can be in any market tomorrow. So good question. Okay, I think time is up. I really appreciate the opportunity to visit with you today, and thank Planet Micro.